The GRCx is an interactive virtual program series designed to support the GRC mission of accelerating the implementation of the city's climate action plan. This program is the second in a series of 3 that explore the intersection of climate, public health, and equity. This series is sponsored by the GRC Higher Education Working Group, which has as one of its goals facilitating collaborative research to promote solutions for equitable climate resilience and mitigation. The first event in this series of 3 explored the historical context behind today's climate injustices and their impacts on our health. If you haven't had the chance to see it, you can find the recording on the Green Ribbon Commission website. Today's program focuses on current research into 3 specific areas: extreme heat, air quality, and healthcare. The third program, which is not scheduled yet, but will probably air sometime in the early summer, will focus on the implications for how Boston implements its climate action work. Before I turn it over to our panelists, a few logistical notes. First, we are recording this session, and shortly after we're done, you'll get an email link to the recording and the slides. So you will get the slides, and all of that, again, is available for past programs on the GRC website, including the slides. If you have questions for the panelists, and we encourage lots of audience questions, please write them in the chat box. The moderator will be drawing from that chat box to formulate the questions for the panelists. And then finally, of course, please mute yourself if you're not speaking. So we have an expert moderator and a wonderful set of panelists here today. I want to thank them all for taking the time to work with us and bring you this information. I'd like to introduce our moderator, H.G. Chissell. Many of you will know HG as the founder and CEO of Advanced Energy Group, which is a stakeholder engagement platform designed for leaders and organizations committed to systemic change in energy, equity, and resilience at the city and regional level. HG is a deeply experienced facilitator who's designed and led over 100 stakeholder challenges involving thousands of leaders and speakers across the US and internationally. Currently, HG serves as the co-chair of the Diversity, Equity, and Inclusion Committee for the New York City Energy Consumers Council. He's a board director for the New England Clean Energy Council, NECEC, and a leadership council member for the American Association of Climate Change Officers. We're fortunate to have him here today moderating, and I will turn it over to you now, HG.
Thank you so much, Amy. This is truly an honor to be able to support the great work that you've been committed to with the Boston Green Ribbon Commission. And I just want to express my gratitude for being here and the opportunity to engage in a discussion with our excellent speakers. At Advanced Energy Group, we believe that systemic change is best accomplished as a team sport. So every quarter, we host our AEG Stakeholder Challenge, which is a 3-part competition, which is designed to engage public and private stakeholders who are willing to prioritize critical obstacles and hold one another accountable to deliver 12-month solutions as cross-sector teams. Our discussion today really, I think, centers around one of the cornerstones of our approach, which is understanding the problem before we rush to the solution. The more we can truly appreciate and tap into the urgency of a problem, the more we can touch our conviction to work together and make an impact now. I did want to let the group know that our next AEG Stakeholder Challenge in Boston is May 19th and 20th. The topic is buildings and construction. Ben Myers of Boston Properties will be one of our speaker challengers. If you have an interest in that, I'm sure we'll find a way to get back to you and tell you more. So today, we are here to discuss obstacles standing in a way of a better future to protect the lives of millions. Our first speaker to set the stage for this important discussion is Dr. Aaron Bernstein, who prefers to be called Ari. Ari is the interim director at the Harvard Center for Climate, Health, and Global Environment at the Harvard Chan School of Public Health. Ari is also a pediatrician at Boston Children's Hospital and an assistant professor of pediatrics at Harvard Medical School. Ari focuses on the health impacts of the climate crisis on children's health and advancing solutions to address its causes to improve the health and well-being of children around the world. Ari, welcome, and so glad you can start things off with us today.
Thank you very much, HG. I share the sense of gratitude that you have for being a part of the session. It's really an honor to share this session with such a great group of folks whom you'll get to hear from shortly. My task here is to give a global to local view of the issues we face to address climate and health in healthcare in Boston. And I will start by saying that the healthcare system in the United States in the last year, comes as no surprise, was pushed to the brink. COVID did extraordinary things in the most awful ways to our lives, to the people who work in healthcare. But it's important to know that even before COVID hit, healthcare in the United States was on the ropes. There were a record number of hospital closures in the country in 2019, and the strains of COVID are likely going to accelerate that, particularly in the healthcare facilities, including in our own state, that serve vulnerable people. This challenge of providing healthcare, the financial realities, is despite us spending nearly $4 trillion on so-called healthcare. I say so-called because the reality is we don't really provide healthcare in this country. We provide sick care. A publication in the Lancet Public Health just a few months ago found that 1 in 4 of every healthcare dollar spent in the United States is spent on conditions that are entirely preventable. That estimate, by the way, did not include the preventable harms from air pollution, which, as we know, is responsible for hundreds of thousands of deaths in the United States a year, and has substantial disproportionate burdens on low-income individuals and people of color, particularly Black Americans and the Latinx community. To put that sum of money spent on preventable illness in context, if you aggregate it together, it would be greater than the GDP of every country on earth, save for the top 19. What we need in the United States is healthcare. We spend a lot of time talking about how we're going to pay for sick care, but you can imagine that if we took a fraction of the quarter of preventable disease, money spent on preventable disease, and put it towards healthcare, we could achieve enormous health gains, save huge amounts of money, and have more productive and healthy lives, particularly for those individuals in our society who've been most harmed by the causes of preventable disease, whether that's heat or air pollution or many other causes. So let's bring this down to Boston. So I work in the Longwood medical area, and there are really two fundamental challenges on climate and health and equity in the LMA. The first is the Maytep power plant. The Maytep power plant was built in the 90s as a cogen plant. It's a gas-fired power plant that provides electricity, steam, and heat. It was established as a microgrid, so it provides electricity, all these utilities, to all the hospitals in Longwood, Harvard Medical School, the dental school, the colleges of the Fenway, and other buildings in the neighborhood. At the time, it was seen as a major advance because it provided stable supplies of these utilities in the event that the grid in Boston should fail. And the plant itself has been retooled to make it, for a gas plant, highly efficient. But nonetheless, it is a 100% fossil fuel-based plant. And there is no plan to address decarbonizing it at the moment. At the same time, it's become increasingly clear that the Maytep, despite its intent of being resilient, is increasingly vulnerable. We know that it is reaching its peak capacity based upon what we've observed in recent summers and calls by the plant to have people in various buildings turn off resources because they were concerned about it not being able to be manned. It also suggests that the interconnectivity of the LMA to the Boston grid is limited, which is to say that if the Maytep plant fails, it's not clear how power or other utilities would be provided into the Longwood medical area. The risks of failure of MATEP are in effect are affected by climate change. The MATEP plant is on the cusp of projections for risk from the combination of sea level rise and storm surge. So it is risk of inundation, as is much of the LMA. So these are real concerns we have to take seriously. The second is traffic. Anyone in Boston knows traffic is a problem. It's particularly a challenge in the Longwood medical area because, of course, that traffic isn't just about the air pollution that comes from it. It's about the ability of people who need emergent medical care to get to the hospitals. There's some 500 ambulance trips to the BI, the Brigham, and Children's every day. That ebbs and flows, but on average. There are over 100,000 people who commute into a 10-block area every day in the Longwood medical area, in the non-COVID area. And we are building more buildings, asking more people to come to these institutions. And we do not have a plan to address the already crippling traffic problems, not to mention the air pollution problems. So in short, we have a real opportunity here through addressing the reality that MATEP, by some estimates, is the lion's share of carbon, Scope 1 carbon emissions from power plants in the city of Boston. So there are several power plants within the city limits, but MATEP is one of them. It is a very high performing plant, but nonetheless, it is a major carbon source for the city, or for that matter, for Harvard to meet its obligations as expressed to decarbonize. There must be a plan to address the carbon emissions from MATEP. We also have an opportunity to improve access to the hospitals, decrease air pollution. It should be noted that the air pollution in Longwood can affect neighboring communities, not just the people who are critically ill within the hospitals potentially, but there's an opportunity to improve access to ambulances, improve air quality, decrease transit times, people sitting in cars. So all of those things, of course, can save healthcare costs, for which, as I started, are substantial. And then, of course, just getting back to the reality that we do provide mostly sick care, it turns out that climate change is driving immense expense in the healthcare industry. Hospitals are being forced to put in storm walls and address paying more for reinforcements to power supplies, redundant systems, all because of the growing threat of extreme weather, whether that's hurricanes, heavy downpours, or heat waves. And to be clear, the evidence is that the hurricanes in the Atlantic basin are getting more dangerous with climate change. And there's some evidence that suggests that their tracks are moving further northward, which puts Boston at increased risk. So we have a lot to gain by focusing locally on the global challenges we face in healthcare. I think we would be wise to address MATEP. I know the Green Ribbon Commission now has, or I've understood that it has a task force that's specifically looking at MATEP. I think our hospitals need to work with the city to formulate transportation plans that are equitable and improve traffic issues. This has been tried before, I should be clear, but it is high time for it to take traction again. And I think it would be important to understand the effects of traffic on ambulance times. That data is available and analyzable. So with that, I will stop. I'm looking forward to the Q&A, and I'll gladly turn it back to HG.
Thank you, Ari, and thank you for providing us a landscape for our discussion today. Next, I'm going to go to our next speaker, which is Dr. Jonathan Levy. He is the professor and chair of the Department of Environmental Health at Boston University School of Public Health. His research centers on urban environmental exposure and health risk modeling, with an emphasis on spatial temporal exposure patterns and related environmental justice issues. Dr. Levy, welcome. The floor is yours.
All right, thanks so much, HG, and thanks everyone for coming. So I want to talk a little bit briefly today about air pollution patterns across Massachusetts, and in particular in the greater Boston area, showing some recent data that we have that I think frames the equity part of the story. Next slide, please. So jumping right in, how do you get inequities in air pollution exposure? A lot of it ties back to some of the legacies of historic racism related to who could live where, who could access housing in which neighborhoods, and the subsequent residential segregation. And some of this dates back generations, and some of it is contemporary. So what it means is that people are living in different neighborhoods from one another, and those neighborhoods may have different both assets and liabilities that can contribute to exposures to multiple things, including air pollution and some of the associated inequities. Part of the framework here, though, is an optimistic one of opportunity. And I think hopefully this will reflect in multiple talks that there's really a chance, particularly related to housing as well as the built environment, to address multiple challenges simultaneously. As we're trying to decarbonize, reduce greenhouse gas emissions, we can take steps that will do that, but also make ourselves more resilient to the effects of a changing climate, and also address some of these air pollution exposures and associated inequities. So we can actually kill multiple birds with one stone if we're smart about it. Next slide. So what I want to do is just show a few snapshots of data from some studies that we've been involved in that can help to frame the discussion, and happy to expand or go into other directions as we go along. So we have at BU a joint center with Harvard, an Environmental Health Disparities Research Center called CRESH. And so some of the data I'll show is from that center. Within CRESH, we asked the straightforward but complex in other ways question of, are there inequities in air pollution exposure in Massachusetts, and how is it changing over time? Is it getting better or is it getting worse? And so to look at that, we had data on air pollution levels on a day-by-day basis across Massachusetts for about a 12 to 15-year period. And we slice and dice that to really look at what the patterns were and what the implications are. Next slide. So just jumping to the punchline, and again, happy to talk about the methods at a different point. What this chart is showing is across all of Massachusetts, fine particulate matter or PM2.5 concentrations here over an 8-year period from 2003 to 2010. And it's subdivided by race, ethnicity, as well as urban rural status, because one could certainly hypothesize or make the argument that racial differences could be a function and part of whether people are living in urban versus more rural settings. So in this chart, the dashed lines represent rural settings, and the full lines are urban settings. And what you could see is that everybody is broadly following a similar trend. We are seeing improving air pollution over time in Massachusetts, but where there are inequities that exist and persist. So for example, if you look at the solid lines at the top, you can see the darkest shade line is the Latinx population, which consistently has the highest exposure. The green line, in contrast, is the non-Hispanic white population, which has the lowest exposure, and other groups are in between, the non-Hispanic Black population having the second highest exposures. Next slide. This chart looks at NO2, or nitrogen dioxide. This is a pollutant that predominantly comes from transportation sources, and so unsurprisingly, you see here a more pronounced gap between the rural settings and the urban settings. And then within the urban settings, you see quite a bit of spread among the racial ethnic groups, where again, the Latinx population, so the bluish line, has the highest exposure, non-Hispanic white having the lowest exposure, and other groups in between. And the gap is appreciable. You can see that the green line, the non-Hispanic white urban line, is about halfway between the Hispanic urban line and the rural population. So there are appreciable exposure gaps that, at least visually, seem to be persisting over time, even with improving air quality. Next slide. So one thing we did, I'm not going to get into the weeds of the methods here, we actually used formal quantitative measures to look at how much inequality there was. People are probably used to, in the world of economics, hearing about income inequality and measures to see whether income inequality is going up or down. You can do the same thing for air pollution exposure. And so the chart on the left is fine particulate matter. The chart on the right is NO2. And here we're looking at it by race, ethnicity, which I showed previously, as well as by education and income. And I see in the chat someone wants links to literature. I'll send along the references later. These data are from a paper by Anna Rosofsky published in 2018. And so what you can see in the charts is first by race, ethnicity, displays the greater inequality versus education or income. That's the bluish line that's at the top, where higher is more unequal. For PM 2.5, you see more inequality that exists in urban settings versus rural. You don't see a whole lot of change over time. It kind of bounces up and down, but perhaps some slight trend to increase. For NO2, you see, again, more pronounced disparities by race, ethnicity than for education or income. And you see a fairly steady increase in this inequality over time. So even as things are improving, we are not addressing the relative gaps among racial ethnic groups. Next slide. So pivoting to the next element, this is from a follow-on paper also by Anna Rosofsky, and again, I'll share these references. The air pollution that we are exposed to, a lot of that occurs inside our homes or other buildings. We spend most of our time indoors, probably now more than ever, but even pre-pandemic, we didn't spend a lot of time as a society outdoors. So part of the question is, of the amount of air pollution that's outdoors, how much infiltrates an indoor environment? So in this analysis, we actually modeled infiltration rates or ventilation rates for every building parcel in Massachusetts based on publicly available data. For any individual home, this is of course quite uncertain, but it is broadly capturing structural trends related to things like age of home and location of home. So we modeled, you can see in the upper left panel, air exchange rate by parcel, and this could get linked then to the outdoor air pollution by parcel, which is in the upper right panel. And then we overlaid demographic features, the Latinx population at a block group level and household income at a block group level, just as a couple of examples on the bottom. Next slide. And so jumping right to the punchline, here you see a couple charts. The chart on the left shows looking separately at ambient air pollution and air exchange rate, or AER, and what the racial ethnic differences are for those. So in this case, working left to right, low is outdoor air pollution below the 10th percentile, high is above the 90th. And so those first two bars are showing basically the patterns I showed previously, that there are racial ethnic disparities in exposures to outdoor air pollution. The next two bars for air exchange rate, you see similar patterns where those with lower air exchange, tighter homes tend to be much greater non-Hispanic white, much greater Latinx, Black and Asian populations in the high air exchange or leakier homes. And when you combine the two together, you get the chart on the right, where the low people have low outdoor air pollution, tighter homes. The high people have high outdoor air pollution and leakier homes. And you can see stark racial ethnic disparities there. So it's not just those who live in places with high outdoor air pollution, they're also having higher exposures to that air pollution as it infiltrates into the home environment. Next slide. Now, the next piece of the puzzle here, that's talking about the outdoor air pollution coming in. We, of course, also have sources of indoor air pollution in our homes. This is from another project as part of our center. The reference there is a paper by Mi-Zung Chu. And this is from a study where we measured air pollution inside and outside of homes in both Chelsea and Dorchester. I'm only showing the Chelsea data here today. And we also collected data on activity patterns, what people did in their homes, as well as ventilation characteristics. Next slide. So jumping to the punchline here again, this slide has a lot of elements to it. I just want to draw your attention to one or two key features. We've divided up here by renters, which were all in multifamily units. That's the chart on the left, and then homeowners in multifamily units in the middle panel and single family on the right side. And in each case, the red bars represent the percent of your measured pollution indoors that comes from indoor sources. The gray bars is what comes from outdoor sources. And what you can see is across renters and homeowners and across the distribution, percentiles of the distribution, indoor sources dominate. But this is particularly the case for renters in multifamily units, where you can see on average upwards of 80+% of what is measured indoors is coming from indoor sources. And as you might expect, the difference between renters and homeowners cuts across multiple demographic features. So renters more likely to be Latinx, foreign-born, unemployed, and without a bachelor's degree or higher within our study population. Next slide. So we asked the question of whether we could explain this. Could we see what factors were contributing to these exposure gaps? And in particular, are they modifiable? Can we change those exposures to reduce the exposure disparities? And so it turned out that 4 factors really explained the bulk of that difference related to indoor sources, and in this case, cooking and smoking were the 2 dominant indoor sources. The use of a range hood as a local kitchen exhaust ventilation, and the size of the building, where if you live in a smaller home or smaller unit, all else being equal, emissions will contribute to higher concentrations. So these features really explain, again, the difference between renters and owners, and therefore some of these demographic differences in our population. Next slide. So I guess pivoting to solutions and the multifactorial solutions, this is a bit of a plug to a commentary I wrote a month or so ago that argued that making strategic investments, in particular in low-income housing, can solve multiple priorities at once. And this was reflecting on the multiple Biden administration priorities. But of course, it reflects locally for Boston as well as for Eastern Mass, that if you invest strategically in low-income housing, that can be a climate strategy, also a health strategy, and a racial justice strategy. Next slide. So this just expands upon that. And if we're strategic with our housing upgrades, meaning things that address energy efficiency or structural integrity, there's a whole host of benefits, especially in lower income populations. Making folks more energy insecure is a high priority that can obviously allow people to utilize air conditioning in the summer or heat in the winter, which is good for both health and comfort, and also can just help people to have more money to invest elsewhere. As mentioned, can address greenhouse gas emissions, improve outdoor air, less electricity use or less fuel combustion means better outdoor air, and it also improves indoor air, makes us more resilient to extreme weather events. But it has to be done carefully. You can't magically get all of these things at once. And in fact, sometimes if you're not wise about it, you can push in one direction and inadvertently cause problems in another one of these dimensions. Next slide. So what you can see here, this chart has a lot of lines, but just want to draw your attention to a couple features. This is by a paper by Lindsay Underhill, modeling the effects of interventions at the Castle Square development in the South End, where they did a deep energy retrofit. And she looked at basically, if you took a bundle of interventions as was done versus slicing and dicing it, what would happen? And so what she showed is if you took weatherization and then added in exhaust fans and HVAC filtration, that's the green lines, you actually saw improved air quality even for households that cooked a lot and smoked a lot. That's in the far right-hand side. In contrast, if you only did weatherization, tightened things up, and you didn't have local kitchen exhaust or HVAC filtration, you made indoor air quality worse, and that could contribute to health challenges for the household. So again, strategic incorporation of measures meant to address indoor environmental quality while you're also dealing with energy efficiency, you can get to a win-win situation. Next slide. So to wrap up, again, we have certainly some air quality disparities in Boston, greater Boston. We can address some of these through strategic investments in housing. I think there's tremendous opportunities, especially if we target it toward communities of color that have been disproportionately affected for quite some time and are vulnerable to the effects of climate change. I think there's some tremendous upside potential. And I'll stop there. I've seen some questions in the chat. I'll try to respond to them while others are presenting, then happy to talk more in the Q&A. Thanks.
Great, thank you, John. All right, next we're going to go to Dr. Madeleine Scammell. Madeleine is an associate professor of environmental health at Boston University School of Public Health and a JPG Environmental Health Fellow at Harvard School of Public Health. Her expertise is in the area of community-driven and community-based participatory research and includes the use of qualitative methods in the area of environmental health and epidemiologic studies. Hello, Madeleine, welcome.
Thank you so much. It's great to be here. And thanks to the Green Ribbon Commission for inviting me and all of the past speakers. So I've got slides. I think they'll be up soon. There we go. Thanks. I'm talking about heat And I am the co-PI of the Chelsea East Boston Heat Study, which is a partnership of investigators, including John Levy, my chair at BU School of Public Health, and the grassroots environmental justice organization in the city of Chelsea, Green Roots. And full disclosure, I have lived in Chelsea for almost half my life, and I'm a board member of Green Roots. I am one of the owner-occupied, single-family, white, highly educated residents of the city. Next slide, please. Thanks. So this is the website and our Twitter handle for the Sea Heat study, and I'll talk briefly about some of our work. But in this short time, I hope to scratch the surface of what do we know about heat and what can we do about it. So we started doing this research in the spring of 2020. We recruited 22 participants for intensive temperature monitoring and questionnaires during the summer of 2020, virtually at the height of COVID in Chelsea and East Boston. And suffice it to say, that was challenging. And I want to give a shout out to our municipal partners in both cities who really assisted, and our advisory team comprised of numerous stakeholders. Next slide, please. But by way of introduction, I also want to share some of my story in terms of how I started studying heat. I started with a disease, a form of progressive kidney failure, very common in El Salvador and Nicaragua and Central America and some other hot spots in the world, all just north of the equator. The most affected individuals are manual laborers, agricultural workers living in high poverty. Next, please. While no one knows the causes of this chronic kidney disease of unknown etiology, heat stress is the most widely agreed upon common denominator in all hypotheses. The combined effects of heat and physical exertion on kidney function is not a new discovery, as indicated by this publication from 1974. However, the mechanisms are not completely understood as to why we would be seeing this epidemic today. You can click again, please. The name heat stress nephropathy has been applied to this illness, and it's widely agreed upon that it's likely a combined effect of repeated exposures to extreme heat, physical exertion, and other stressors, including dehydration, exposure to pesticides, and heavy metals. Next, please. I wrote this article highlighting the injustices associated with both the disease and climate change. We're more likely to see things about climate justice. But whether or not this disease that I study is actually linked to increasing temperatures on the planet, as several diseases most certainly are. In both Nicaragua and El Salvador, hemodialysis is extremely difficult to access. And for the majority, the diagnosis is considered a death sentence. It's leading to fear and stigma associated with the diagnosis. And this is not necessary. This reflects a lack of investment in healthcare systems and studies of the root causes of disease for the purpose of prevention. Next slide, please. So this image, is, I'm following my notes along here. All right, this image has been seen in this series before. This piece by Martha Biebinger talks about areas of the city of Chelsea known as urban heat islands and the health conditions exacerbated by extreme heat. This is a great piece, and if you go on to the next slide, you will see a visual that has also been shown before, similar in this Green Ribbon Commission series. Old maps showing areas of communities that were redlined. And this shows Chelsea on the top, East Boston on the bottom, the areas that we're studying in the Chelsea East Boston Heat Study. What we know is that the urban heat islands we measure today, where there's high temperatures, are correlated with areas that were historically disinvested in redlined, so-called. We know this. Next slide, please. So what else do we know about heat? Heat is referred to, thanks, as the silent killer. It's the leading cause of death from weather-related events. So flood, fire, tornadoes, unlike those, we don't see, smell, or hear heat. And it's likely to increase with climate change. And you can click again. This infographic highlights physical conditions that can result from heat, including cardiovascular and respiratory outcomes that also result from air pollution that results in inflammation of the airways. So this is true of heat exposure as well, and the children and the elderly are the most susceptible, have the most difficulty coping with extreme heat, and people who have pre-existing conditions that take medication for controlling blood pressure, for example, also have their cooling capacity diminished. Their thermoregulation is affected. Next slide, please. So this World Health Organization figure also talks about the direct and indirect impacts of heat, and starting from the top right, in addition to these symptoms of heat-related illness, heat can disrupt our sleep, contributing to poor mental and physical health, in addition to directly affecting our cognition. And the indirect impacts of heat are numerous, and ultimately social economic position makes it more or less difficult to manage heat financially, environmentally, and behaviorally, including seeking healthcare. So working a hot job, decreased physical capacity, housing instability, all of these things make it more likely that heat will affect our health. Next, please. And this figure emphasizes the fact that heat-related deaths do not equally affect everyone in the United States. Here, undocumented individuals account for the vast majority of deaths attributed to heat. Non-US citizens age 18 to 24 were 20 times more likely to die from excessive heat exposure than were people with citizenship status in this country. Over, from 9 years. And in the 3 agricultural states, California, Arizona, and Texas, 96% of the deaths are among non-citizens and mostly farm workers. Next, please. So what can we do about this? Well, one of my favorite movies, and it just occurred to me this week that Do the Right Thing took place during a heat wave, one of the hottest days of the summer in July. It's been 32 years since the film was released, but Spike Lee knew it back then. Bedford-Stuyvesant, you can click again. The neighborhood of Brooklyn where this film took place is an urban heat island that ranks high on the heat vulnerability index created by the city. And I apologize, I didn't give attribution on this map, but I'll fix that. So the film depicts social tensions as well, conflicts with the police that also rise with the mercury, and you can click again. And studies since then have shown that as temperatures rise, so do violent crimes. Not all crimes, but particularly violent crimes, including homicides. So again, what do we do? I think we need to think about this in the context of health care, not sick care, as Ari said earlier, thinking about the true definition of health being the complete state of physical, mental, and emotional well-being, not merely the absence of disease. Next slide, please. Also in the film, there's a great scene of relief when they broke open the hydrant and sprayed. And now today in New York City during the summer, anyone can go get to the fire department and literally get the key to open hydrants to cool off in a manner that doesn't reduce water pressure for everyone all around. click. And misting stations are now more common in other countries, Mediterranean countries, and are increasingly being studied here. So this is one of the things that we hope to study this summer. Misting stations decrease skin temperature, increase thermal comfort when you have water combined with wind. Next slide, please. And in the city of Chelsea, with support from the Barr Foundation, just last summer, we were able to install a number of hydration and misting stations throughout the city. And we hope this summer to observe who is using the stations and how. So next slide, please. Now I'll transition to talking about some of the things in the Sea Heat study. We asked participants about hydration, and of 22 people, only 6 reported drinking 1 or 2 glasses of water each day. Half felt they knew they didn't drink enough water, and all but one of those people who reported not drinking enough water also experienced headaches. So headaches are associated with dehydration. 7 of 10 reported 3 or more symptoms of heat-related illness during our study period. Next, please. We also asked about air conditioning use. Everyone had an air conditioner in their homes, yet many described the living conditions as hot or warm over the prior summer. And some reported never having used their AC, even in the daytime or the night. Next, please. And we can only imagine that that has to do with financial health. So there was a high rate of unemployment among our participants. 50% said they have to make very difficult decisions about the utilities that they're going to pay. And so things that we hope to do this coming summer, next slide, please, include really examining the opportunities for tenants, for renters to upgrade their air conditioners and get assistance with utilities, as well as look at building-wide interventions also available through entities like Mass Save. Next, please. We also asked about transportation, and we learned that 80% of our participants rely on public transportation, and this increased to the reliance on private cars increased quite a bit during COVID and due to heat. So I know this is inconsistent with the Green Ribbon Commission priority of carbon neutrality, but providing vouchers or rides to vulnerable residents during heat waves would be a possible intervention, and they could be electric cars, potentially solar powered. Next slide. But what more can we do? So I want to acknowledge how lucky we are in Boston to have the Boston Public Health Commission and such coordination already with healthcare and innovation. I'd say no other city or town in Massachusetts is as fortunate, but still much of our work is focused on new developments and new construction, new vehicles, and there will always be poor people living in poor housing, old housing in particular. So I propose you can click some more inclusive solutions for reaching the most vulnerable populations at risk, recognizing heat-related illness, including chronic kidney disease, which is observed in hospitals here among people from Central America as a health disparity condition, examining unequal exposures to heat where we live, work, and play, and implementing multi-sector prevention strategies. So as described, this is about prevention of sick care that is healthcare. So housing codes that consider heating and cooling for residency permits, prescription air conditioning, shades, perhaps window screens that keep insects out, and also prescription utility assistance and weatherization. I know some of these are being piloted, and then ultimately evaluating environmental enhancements that could reduce urban heat island effects while also reducing exacerbation of heat islands, which is burning fossil fuels and in boilers and vehicles. Next slide, please. Just to tell you, I have 2 more slides. We're going to be doing in-depth interviews and participatory action research using photo voice this summer to get a better sense of how residents are really coping with heat beyond what we can understand from questionnaires and surveys. And this will culminate in a public photo exhibit that I hope you will all be invited to. And next. We are also working with youth on a surface temperature monitoring campaign. So surface temperatures correlate with ambient temperatures. They seem to be very aware of the history of redlining and correlation with heat islands. And we hope to use collaborative mapping tools as well as bring attention to the hydration stations. So the next slide is my acknowledgements, and I want to thank the team that are on the call, and thank you all for listening.
Thank you so much, Madeleine. Next, we're going to go to Kalila Barnett. Kalila joined the Barr Foundation as the Climate Resilience Program Officer in 2018. Kalila has over a decade of experience in community organizing around affordable housing, land development, and environmental justice. She served as the executive director at the Alternatives Community and Environment, ACE, for 8 years. Kalila, welcome. The floor is yours.
Thank you so much. Yeah, I really appreciate the opportunity to be a part of the conversation today. Want to share a little bit more about Barr's climate team and how we're working to center racial equity and why. And we'll also say a little bit about why linking climate and health requires a racial equity lens. You know, I am not an expert in the scientific analysis, you know, behind air pollution and heat, but as a person who's born and raised in Boston and Roxbury, in a community that is deeply affected by all of the issues that we've talked about today, this is something that I care deeply about. So next slide, please. So the Barr Foundation as a whole has really reaffirmed its commitment to racial equity, and we really believe this to be a long-term commitment of the foundation. We are expanding this commitment to diversity, equity, and inclusion, and focusing on anti-racism. At the same time, our climate goals remain the same. We have 3 strategies around clean energy, trying to transform the Northeast energy system by accelerating equitable, clean, efficient, and modern energy system. We work to address mobility, reducing transportation-related emissions by modernizing the transportation sector and accelerating the development of low-carbon communities. And then finally, my focus area around climate resilience is about increasing the capacity of Metro Boston's residents, public sector, private sector, and vulnerable communities to prepare for and adapt to the impacts of climate change. Next slide, please. On the climate team, we have some core beliefs that are really driving how we conduct our work. We believe that the fossil fuel-based economy that is degrading our climate includes a legacy of laws, policies, and practices that impose a disproportionate environmental burden on communities of color and people living in poverty, while preventing them from benefiting from climate mitigation, adaptation, and resilience efforts. We believe that we cannot effectively address the climate crisis without addressing this history of systemic environmental racism. So in our grant making, we prioritize communities that have been historically harmed and are presently being harmed by the fossil fuel economy. And those are the same communities who have also contributed the least to the climate crisis. And in doing so, we believe this enables us to support a stronger, more inclusive climate movement, one that elevates those voices and the solutions that comes from those communities to be able to improve public health and generate economic opportunity that is accessible to everyone. Next slide, please. So we believe that the most powerful strategies for reducing greenhouse gas emissions and making our communities more resilient to severe climate events are those that center the health and the well-being of people of color and those that are living in poverty. And so as the previous participants just described, climate change is a threat multiplier for inequality. And unfortunately, the needs of those who are most negatively impacted are often not centered or sometimes not taken into account when we make plans about how we're going to take on the climate crisis. Because we often look at technical solutions that are focused on how do we address hazards rather than people, we can't build climate resilient communities by only focusing on climate-induced disaster events. We really need to think about how do we build resilience before those extreme events happen. And to do that, we need to be able to address the underlying causes of vulnerability, which the previous panelists spoke so eloquently to in detail about what some of those vulnerabilities are. So how do we do that, addressing vulnerability and the climate crisis? One of the ways that we can do that is looking at all of this through the lens of health, the health and well-being of our communities and those that are impacted the most. And so through that lens, we can see that climate change worsens already bad health outcomes for communities of color, and that many of the solutions that will make our communities healthier will also make our communities more resilient to climate impacts. That's been demonstrated through the conversations, through the work of John Levy and others, looking at housing, looking at heat impacts, looking at how do we get to our medical appointments in the Longwood medical area without much burden. Through linking climate change, which for people outside of this, those who are most engaged in the conversation, climate change still remains kind of an overwhelming, vast topic where people are struggling to figure out where is my place in this and what work do I really do. Through linking climate change with health, we can really demonstrate how this is connected to people's everyday lives. Often when you talk to folks about where climate change ranks, it's on the list of priorities, but there are a number of things that are ahead of it: housing, jobs. And it is our work at the foundation, we believe, to really support efforts that are helping to make that link. And making that link is really critical because if we're going to win the kind of policy and societal transformation that's really necessary to achieve our climate goals, folks have to see their self-interests represented in the climate movement. That is how we are going to build our power. That is how we are going to win. Thank you so much for the opportunity to share those brief thoughts, and excited to get into the conversation with the rest of the panelists and those who are attending the webinar today.
Thank you, Kalila. I feel like you really brought together a lot of the thoughts that were circling in my mind after hearing the problems presented by the other speakers, and how do we activate human behavior towards change? And I thought maybe if we go back, Ari, to your point about healthcare versus sick care, which was referenced by almost every speaker. So it's clearly resonating as an important distinction. Say, for instance, Ari, this program was heard by Bill Gates, and he was inspired by your remarks on healthcare versus sick care. And you were asked to address how do you start focusing on making a change towards healthcare versus sick care by Bill Gates. What would you say?
Well, I would listen to my fellow panelists is what I would do. You just heard a pretty articulate set of actions that could be taken from the integrated approach to indoor air quality that John said, Madeleine and Kalila really focusing on the intersection of really the completely inseparable intersection of equity and health. The question I often get asked when I talk about this conversion of sick care into healthcare is who can we tap to do that? You know, there are folks in healthcare say, you know, we don't know how to do this. We wouldn't know, you know, you threw money at us. We don't have the people, we don't have the expertise. And so I think there's a real question there about the money is coming to healthcare. That's where the dollars are. But who are the folks that can do this effectively? And we see pilots. So if someone had, you know, wanted to get behind this, I think what we often see are the grassroots community organizations that look in an integrated way at the welfare of the people in those communities and say, here are our priorities. And that's where you have to start. I mean, whether it's the indoor air quality or urban greening or any of these initiatives that we heard about, they flop when they start without the community's voice. And so that to me is a critical piece. Now, how you get the healthcare dollars into their hands it is a policy choice. Now, in Massachusetts, we actually have a huge opportunity because we have publicly sourced healthcare, right? Now, we, in my view, made a mistake in Massachusetts in contrast to Ohio when we implemented what we call accountable care, which is the idea that healthcare organizations get paid sort of a flat rate for caring for people in their purview. And we disaggregated it. We said, we're going to treat everyone in a household as can have a different so-called medical home. Well, what does that mean? That means if you stop one person from smoking, the only benefit you see is that one person. The other three people are in different systems. In Ohio, they said, we're going to do it by household. So if you have two parents and two children, one person stops smoking, you get the benefit of all those people benefiting. So they're very simple policy changes, like in our public insurance, Massachusetts, we should move, in my opinion, to a system where you have it based on household. This is particularly important in light of what you heard from all my fellow panelists about what we see in the inequities by race and income and multifamily rental housing. So, you know, those are the people who have the greatest percentage of their incomes going to utilities. They have often the highest rates of healthcare utilization that's preventable. I might also add another thing that we can do locally is work with the financial community to provide incentives financially to help cover those costs, right? So if you de-let an apartment, you should be financially incentivized in your mortgage. If you do that suite of activities that John pointed to in indoor environments, either landlords or owners should have a discount in their mortgage because it's going to save the state money. So, you know, these are mechanisms that are very real, very doable. These are policy choices, and we have evidence, as you heard, to get at them.
Thank you. And have you seen an increase in heat-related illnesses per Madeleine's presentation? Yeah, I mean, it's not news that heat is a major source of ED utilization. We just looked at, we have a study in press right now. We looked at emergency department use across most of the nation's children's hospitals. And we found not only is there an increase in all-cause visits, which was not surprising, meaning for any reason, but there were very surprising findings in terms of the kinds of conditions in children that we're seeing increased rates of visitation. So you expect, you know, dehydration. You don't necessarily expect infections, but it turns out infections were a big piece. Neurological conditions, so children's having seizures. There were several things that popped out that were very surprising. And again, for children, you know, we tend not to pay attention to them in public health as much as adults. I think we can do better, but there's no question that children have major health risks, and pregnancy, for that matter, as you heard from Madeleine, is a major point of risk. Thank you. And I do want to encourage everyone who's listening to share your key takeaways and questions with us that we need to be discussing to how do we go from the problems presented so powerfully today towards pathways to overcome them. I think I'm going to walk away from this discussion knowing the pain points greater than ever before on these issues, but I'm also going to walk away concerned on how do we catalyze this into effective action. And if you have questions on how we need to go about that or things we need to be thinking of, please share that in the chat. Did any of those questions come up for the other speakers? Listening to what you heard on and how do we move forward? Kalila?
I can briefly maybe build on some of that are saying, I do think there are opportunities and there are places, within and outside of healthcare where people are thinking outside the box and creating novel policies. I'm thinking about Boston Medical Center, for example, who serve a number of vulnerable individuals throughout the city, where they've made explicit investments in housing and housing supports. They also are growing their own food on the roof of Boston Medical Center, which they provide to patients. And so I think they understand that these are wise investments to try to prevent downstream problems. Now, how do you get that to be more systemic across the healthcare system? That's a whole other question that's kind of above my pay grade. But I think you can see that some of these hospitals and folks in healthcare, realize that things like housing, food access, energy and food insecurity are actually incredibly important for health. And I think Ari's right that there are a number of policy levers that we can take advantage of. These are policy choices. And so lack of action is a policy choice. We're choosing not to do these things that we know evidence shows are protective of vulnerable populations and can improve their health in the long term. And so some of it is about split incentives. Some of it is just about people just not wanting to do things differently from the way they've been done. But I think there's a lot of compelling evidence that says we can have some wise targeted measures that are true public health measures that will improve the health of populations and help to create a healthcare system that is more about enhancing health versus dealing with the downstream disease.
And do you feel that we've got the right universal metrics to judge our compassion on these issues? Are we you work at a factory, 0 days until there was a health accident, or there have been 10 days, and you constantly check going through a day without losing someone on that job. Do we have the right metrics in front of us to activate our compassion in ways that we have so far on these issues?
I mean, personally, and I'll let Madeleine chime. I think the data are there. It's about utilizing the data and understanding maybe when and how to intervene. I mean, the fact that there are strong racial and income-based disparities in health outcomes like asthma or cardiovascular disease or diabetes, that's not new. Those data have existed for a long time and are in the hands of the healthcare establishment, politicians, community groups, and others. So we all know that the disparities exist. The data are out there. The question is how to act on them. Sorry if I stepped over you, Madeleine.
That's okay. That's part of your question, HD, is part of why I wanted to show the Do the Right Thing film. I almost wanted to play the trailer just because I think that there's a combination of not having data, say, on what's characterized as a heat-related illness in hospitals or ED visits that could be then correlated in studies of heat or to identify vulnerable populations. But on the other hand, we have the experience of communities who have known about some of these relationships for a long time. And we need to do more to think about the data, I think, as Kalila said, from a human-centered lens, and find both tech solutions and individual, people solutions.
Thank you. And we're getting some great questions in the chat. So thank you, everyone, for jumping in and getting in there. Kurt, Elise, Tracy. Let me just go and take a couple of these and start the presentation here. So Lisa Cunningham points out that the laws need to change. We can't continue to allow new fossil fuel infrastructure to be built. And the public health community needs to reinforce this message, which goes right into a question of what are the role of healthcare institutions in all of this, especially given kind of Boston's unique standing as a healthcare institution kind of center. As you were talking, Ari, I went and did some research, and Maytep is owned by NG, which is a global leader out there committed to decarbonizing. They have a really active stance on that. So how do we connect some dots here and get the healthcare institutions practicing healthcare?
The Green Ribbon Commission has a critical role here, HG, and it's something I've worked on personally. We worked very hard to get every single healthcare institution along with medical area commit to decarbonization. And the immediate consequence of that is what are we going to do with Maytag? And to your point, NG, they're a power company. They don't want to build more fossil fuels. They want to find ways. It's the stakeholders that aren't working together. We need a moderator to get these folks to the table. Now, there are some folks who are pushing harder than others within the LMA, but the bottom line is there needs to be a concerted effort, and every hospital needs to be at the table. And there needs to be a plan, because whether it's for resilience, and I don't think our healthcare leaders understand the vulnerability of the system they have bought into as well as they might, because I think if they did, they might think very, very quickly about having an alternate plan. But that aside, we have a decade, like the message on Earth Day, this is the decisive decade. If we cannot get ourselves off fossil fuels, if we cannot get healthcare off of fossil fuels, which in the United States, we account for something like 5, maybe 10% of the entire greenhouse gas emission inventory of the country, healthcare alone, we're going to have a much harder time getting where we need to go. So we need to lead. We have institutions that can lead. We distinguish ourselves by leading. We simply need to get that's why the GRC exists. We need to get these folks working on it, and we need to give them reason to do so. I think it's very important. It was clear to me that there's a wide range of understanding among these institutions about why this is important to do.
When I get overwhelmed by that, one place actually that gives me hope is when I see the members of the Green Ribbon Commission. I mean, it's an extraordinary group of highly resourced leaders who are committed to this organization and making positive change. And that encourages me. I see Ørsted, because generation is going to have to be part of the mix. You can't go off natural gas without a viable, reliable alternate. And that's making many people scratch their heads on how to do that. But we need to do that together in order to figure that out, which would be renewable generation somehow that can handle its intermittency, which makes it so challenging. Great comments coming in here. The Ellis, I love what you say here about, if people are passionate, what can an individual do to engage, support, show up? What does do the right thing mean for our Boston? That's a great question for a committed group of stakeholders to start to frame and own as a conversation point.
Yeah, I think that, one of the ways that we begin to address this, as I was mentioning, and work we support is getting organized and putting pressure on decision makers, elected officials, policymakers to make the necessary changes that are required to really address the situation. And so one of the roles that philanthropy is able to play is to be able to resource those folks on the ground who really have a close understanding of what the challenges are that communities are facing. In some cases, like in the example of East Boston and Chelsea, we partner those with lived experience, with academic research and analysis to really help to make the case for why these changes can really move forward. And so there are community-based organizations across the city and the region that are working on the intersection of these issues. And so there's a lot of opportunity to support environmental justice communities, to raise the volume on the urgency of tackling these issues with this intersectional perspective.
One of the most concerning and encouraging things I've seen over the last 9 months was the global shift to wearing a mask. That decision and how we communicated the life and death value of wearing a mask, I felt was just such a huge insight in how can we really work together as a humanity to protect ourselves and be compassionate. Because I'm wearing the mask for you as much as for myself. And that's kind of the dialogue we need to find ways into at scale to make real impact. And I think that was a combination of really feeling the urgency, but also seeing such an alignment and overwhelming consensus that this will help and protect people. How we pull that into these moments are important. I look at what Deb has written here in the chat about, she says that both my kids, both my kids and my wife have asthma. On my street, many people park and idle their cars throughout the night for heat and air conditioning on our street. There's a park across the street, so there is extra parking, but then there are a lot of fireworks. I can't help but think that this is a housing issue because people have no other safe place to go. And this heat and air quality are a concern. So I think this really goes into the housing piece, back to what was talked about earlier, is how do we create safe housing as well?
And I do want to briefly amplify something that Madeleine said, which is really important, because I think when we start to think about, things like climate action, I think we all have the tendency to think about the new, right? What are we gonna do about new housing, and let's get electric vehicles out there right away, and just sort of emphasize the new technologies, new construction, new everything. But Boston is an old city, and most cities are. There's a lot of infrastructure that exists. We're not going to knock down all the houses that exist in the Boston metro area. So the question is not, what are we going to do about new housing, although it's important, but it really has to do with what are we going to do about our existing housing stock. Like, that's where the disparities are, that's where the action is, that's where the carbon reductions could be greatest. And so I think we have to really have that lens of, like, what are the housing that particularly low-income communities or communities of color are living in, and how can we invest strategically in a way that is health promoting. So I think that groups like this and others have to just keep steering us away from, like, the shiny new object down the line, and thinking, like, how do people live in the here and now, and where can we make strategic, if unglamorous, investments that can improve health and reduce carbon emissions.
That's a good point.
Yeah, and I think housing is particularly important because, in addition to all of the health issues that are related to bad, indoor air quality, et cetera, we also have an affordable housing crisis in our city and in our region, in a number of cities across the country. And so, again, it's an opportunity to bring in new stakeholders and new interests into the conversation. There's a large amount of a number of organizations that are doing work around increasing access to affordable quality housing in the city. Those people are not necessarily a part of the climate movement. They don't necessarily see, their interests as linked together. And so there's a huge opportunity there to mobilize a number of people who would not have been a part of the conversation had we not made the choice to look at these issues through centering those who are most impacted.
Good point. I want to point to a comment made by Kurt Newton, who says that we have to make sure that we just don't focus on heating, but cooling as well, which was a great point that came up in a recent discussion I was in with NYCHA, who they have like 110,000 children are in NYCHA housing, 77,000 seniors, where the average household income is only $23,000. And the big concern is when they have the next heat wave. To your points, Madeleine, that you brought up. So Kurt's bringing up that point about the importance of retrofitting homes in this decade. But do you really feel, his question is enough attention being paid in these plans that are emerging to the cooling side of the equation? How do we bring more understanding? We always talk about clean heat, but how do we talk about safe cooling?
I agree. I do think there's room for research in that realm, or at least on my part, there's certainly room for education. When we talk about upgrading air conditioning available to residents, we also have to consider the electrical capacity and the wiring of their home, and if it's old, in addition to their utility capacity to pay their utilities. So yeah, there's a lot of infrastructure upgrade, I think, that needs to be done.
Thank you. Yeah, and I just see another point here about just looking at these great questions that are coming up here. One is from Lisa Winston, kind of underlines a point that Lisa made about what are the obstacles to building zero carbon labs. This reminds me of a point that came up in one of my sessions in New York City, where a woman who's head of deep decarbonization for a very reputable advisory, JB&B, to major commercial A real estate, said that the biggest problem is uncertainty. These major decision makers stay in uncertainty right now and don't move into action. And if there was some type of a zero carbon lab where they could go inside it and see that this would actually be a good decision versus one that had risk, they could lead to more action. Do you see any examples of zero carbon labs showing up where we could see the benefit of these issues? Not yet. So that's a good one that was put on the table to get people to appreciate it. I think there's some quote about the moment you appreciate change is when you can appreciate its benefits. Until then, you have a natural resistance to it.
I just wanted to add something to a point that you made just before you read that comment about the emphasis on heating versus cooling. And, you know, I think just as a result of the region of the country in which we live, you know, utility programs are often designed to support those who are trying to heat their homes. But, you know, there is a lack of support for infrastructure to help people cool. And so the LIHEAP program, which provides utility assistance and helps people to address their energy burden, is really focused on the winter and keeping people warm. And so one of the things that folks are beginning to think about is opportunities to expand that program. It'll need more resources to also be able to address summer heat.
That's good. Right. I'll share one thing I've noticed recently with Eversource is that they have been looking at a program for ways they're suggesting a new approach to solar community credits. So if they do a new approach to community solar, that it could somehow lead to dollars being able to be reinvested in disenfranchised communities, somehow redirecting benefit to support a greater whole versus just an individual. You can see the growing currency that carbon has before. It would be great if we could see a growing currency on compassion maybe as well. Like, this is what I feel so much of this conversation is about, is activating action around compassion. We see these problems, but we can't solve them ourselves. We have to say this is worth it. All right, we've got some other points here about that I'll go through. Appreciate all these great questions that are coming out here. There was one again about this point of back to higher ed and healthcare for Boston. There could just be such help here, but Dallas is bringing up the fact that a lot of Boston's higher ed institutions and perhaps healthcare don't naturally weigh in. They have their government affairs offices focusing on different things. How do we get these big players to actually put skin in the game, since so many of the world's researchers are working in their organizations? How do we bring that next level of accountability and action?
Well, I can say that having served on the Harvard University Climate Change Task Force, Harvard has set a very ambitious goal. It's not just carbon neutral, it's fossil fuel free. BU has set a very ambitious goal. MIT has set a very ambitious goal. So the objective now is to hold these institutions to their goals. I need to be clear that the medical system that is Harvard affiliated is not a part of the Harvard commitment. So the hospitals are not under that obligation. So there needs to be a separate approach. But I think to the questions and comments around labs, in biomedicine, it is the labs that consume vast amounts of energy in contrast to the hospitals, although hospitals are huge energy users as well. And MIT in particular, I should say, has done a lot to try and not only pioneer how to decarbonize and make labs more sustainable, but to try and evangelize around this. I think there's a critical role here, and we've done work, including last week, to address this with HHS. So NIH right now is giving universities 60–80% overhead costs to finance very carbon intensive research enterprises. Can you imagine what would happen if the NIH, which essentially, I mean, you know, this is 80–90% of the funding of most academic biomedical research institutions, the federal government taxpayer dollars are essentially fueling a massive greenhouse gas footprint with 0 strings attached. And we have, and this is, to me, it's unacceptable. And we have asked the NIH to address this, and they have not. So I think we all can do in our academic settings a call out. We serve on review panels at NIH. We have colleagues that do. This is inexcusable given the carbon footprint we face. And frankly, in one way, I think academia, we've stepped up with our institutional commitments, but we have not taken responsibility for the money we're getting to support our enterprise coming from the federal government. I think we can do more there.
So I'm building on Ari's points, and those are excellent points. I do think academia has the opportunity to take these measures, but also has a real obligation to lead. And I was on BU's Climate Action Task Force where we were grappling with the university's plan and commitment, and part of it was, what are the metrics and what are the goals and so forth. But there was a real desire there to say, okay, we shouldn't just be following behind and doing what the city of Boston is doing, but a couple of years later, we should be actually more aggressive, because what universities can do is experiment and research and evaluate. And so ideally the universities are the test beds for actions that can then be utilized by cities. Universities are kind of a microcosm of society. We can try some things, and when there are successes, hopefully have a multiplier effect. And so I think that, I can't speak for other universities. I think that certainly that mentality is happening at BU, and I think it's happening elsewhere, of saying, look, let's utilize our capacity to collect data, examine things, test, and then broadcast it out so that we can take actions and see what works and see what doesn't. I do think, again, Boston has such a amazing collection of universities and researchers around that really efforts can and should be focused on things that are of value to the surrounding communities, and then taking that next step to communicate it out to folks and help people understand what works, what doesn't, and how you can do something that's really beneficial and health promoting.
That's a great point. It seems like such a great opportunity to bring in some master storytellers who can tell the story of this commitment by these critical organizations and tell it in a way that's compelling to inspire people to get involved, but also to send a clear message that things need to change. I see it now with the automakers making decisions that after this date, we're not making any more fossil-based cars. Those messages just have such reverberations into the infrastructure that has to change. And seeing ways that maybe that could be done on these issues when you have a consortium of universities making that commitment that you mentioned, perhaps that does make the debt necessary on the gas infrastructure that's seen as so reliable, it's hard to walk away from, so that there could be a new future for MATEB, one that could actually be one that could maintain its reliable components, but also be one that doesn't have that pollution. I got another one here about the metrics. Going back to the metrics, I want to share this. So I don't think we've got a good answer about metrics yet. We have studied things and know the problem. We have not set metrics connected to the investment and funding that center human health and well-being. One example is the cost effectiveness test for energy efficiency investment. The cost effectiveness is against the next unit of natural gas cost. That is the primary disincentive to substantial insulation of existing homes to a level that would create resilience for low-income homes during heat or cold events. How do we focus on the windfalls of green energy on these human-centered solutions?
So I can say that in the metrics front, one of the things we can do is quantify the health effects more clearly and accessibly. And Joe Allen at the Chance School and others have worked together to do that at buildings. So we've developed tools where you can actually go in and ask, if you improve the energy performance of buildings, how it affects the health of people in the community and downwind, right? So this is particularly useful at a large scale. So we're thinking building portfolio managers, but it can get down to the individual building. The effects are greater over size. And we've taken this tool and brought it to the banks, right? Telling them, there's $80 trillion under investment in the world, and about 1 in 4 of those is for supposed ESG goals, right? So environment, social benefit, and governance. Pretty much 0 of those are health focused. So people are throwing trillions of dollars for carbon, but they don't care about the health piece. And that's a huge opportunity because, think about it. I'm seeing a kid in the emergency room who's suffocating because they can't breathe from asthma. And I look at the parents and I say, let's say I could take all the fossil fuels out of our energy system and that'll provide a livable future for this child. And that parent could be perfectly concerned with climate change. Or we could do the same thing and it'll prevent your child from suffocating in front of both of us. Which one are they going to choose? They're going to choose probably the here and now. But what we've done with our metrics is we've put them on carbon. We've put the cart before the horse. We call the near-term benefits that the parents that I see taking care of and told them that the benefits of the future, which they could be very genuinely concerned about, are more important than the here and now. By calling those here and now things co-benefits, they're not in the financial markets. They're often not present in other decarbonization activities. So I think in terms of metrics, the 2 big messages are: 1, we have tools, we can use them in buildings in particular, and John has pioneered stuff around the grid. There's a whole host of health-based tools. We need to use them, and we need to focus on the here and now and stop talking about putting decarbonization as the first objective. We need to put health and equity as the first objective, because that's what people care about. I mean, it's not that we don't care about the future, but we care about the now more.
Yeah, and Ari makes a really important point that, in at least the research community, those metrics have been developed. Joe Allen has done this, our group has, there's others who've done it, where the question is who's going to use it. And I think one of the big challenges is the challenge of split incentives, right? Like the person who will gain financially from an investment in energy efficiency in multifamily housing, right, is not the same as those who would reap the health benefits through the healthcare system. And so when you have split incentives, you need policy that can align things to incentivize people to take action where they are not going to be receiving all those externalities, those downstream benefits. So I think we know how to quantify them, how to focus people on them is a challenge. But I think we need to find policy measures that basically, encourage people to make investments that will yield public benefits, even if they themselves will not receive the benefits. And again, that there's a lot of vehicles to do that. I think we just have to, again, 100% agree with Ari's point. Like, the near-term human health benefits of these actions are substantial, and if we center that in our decision process, we will do the right thing.
We probably won't get to all the answers today in the last 2 minutes of our time together, but I do know that if we keep having these type of conversations with this level of engagement and hard questions, we're going to move in the right direction. Thank you so much for the opportunity to be a part of this dialogue with all of you.
Well, thank you. Thanks to all the panelists. Thank you, HG. I thought this was absolutely fantastic, and a lot of ideas to spin out from here. I hope you can all join us on May 6th for the next GRCx, which actually, because this point came up so many times today, it focuses on how we are going to go about decarbonizing Boston's district energy systems. So that's a really good follow-on to today's discussion. And on behalf of John Cleveland and me and the Boston Green Ribbon Commission, thank you for joining us.